guys, good morning. My name is Christy. I'm one of the nurse practitioners in the neuro ICU. So just want to thank you all for being here again this morning. I have the pleasure of introducing our next speaker. It's Mrs. Karen Custer. So Ms. Custer is a physical therapy assistant that I had the pleasure of hearing speak for the first time in 2017 at a conference. And I was really just blown away by her drive and her vision and enthusiasm for caring for patients post-stroke. So she developed a program, the Stroke Active Recovery Therapy Program. And today she's going to share with you really how important that process is of just after they get out of the hospital, getting patients to really meet their maximum potential in their recovery process. Ms. Custer, can you come up? Thank you.
Good morning. Is my mic on? Can you hear me? Is it mic on? We're good? Okay, there we go. Okay, I'm gonna put this clicker. There we go. Okay. Well, I want to thank you for inviting me to come back to speak. And I want to thank you, nurses, doctors, staff who actually care for our patients when they're in such great need. And I really want to thank you all for being there for all of our patients. So I have been in fitness and wellness for 25 years. And for the last 15 years as a physical therapist assistant, and the majority of those years, I've been working with hundreds of patients, stroke patients and traumatic brain injury. But today I'd like to talk to you about early intervention and give you some rehab examples and some of the results, mostly the results. If I get to talking too fast, raise your hand and wave at me because sometimes I get excited because of what I do. So early intervention. This is something that Christy and I had talked about before. What is it? What is early intervention? What is early mobilization? So I'm not going to give you reports. I can just tell you a few of the reports that we base our thoughts on. There's multiple studies who've asked that question. What is it? And what do we do with it? What does it look like? There was a study done in 2017. It was called the AVERT study. You probably have all read it, probably all know about it. And they started providing some information. So when we start with the early mobilization, again, this all depends on medical sound, you know, where are they at in their level of function? How do you provide that? But they have proven through these results of the studies that they have increased the odds of a favorable outcome, which is what we're looking for stroke survivors. And nurses, you are the first contact with those patients, and you're the most integral part of that early mobilization. The rest of that MOB team is the patient themselves, the family and the caregivers, and of course the therapists. So in those AVERT studies, they suggest that we start mobilization 24 to 72 hours post-stroke onset and admission. An important note, though, in the last AVERT study, which was one of the largest studies that, as far as they knew that I know of, they said that actually more frequent and less dosage, shorter sessions, had more effectiveness than when they were assessing patients at 3 and 12 months. The AVERT study 2, which was prior to that one, showed that those that received early mobilization walked 3.5 days versus 7, as opposed to those that had received standard care. So the early mobilization, as you guys all know, I'm just going to kind of just start this because this is what I want to move into with what I do. It actually can or may reduce the immobility related to complications, the loss of cardiovascular fitness, and muscle atrophy. It also takes advantage of that period of time when we have the very sensitive neuroplasty during the earliest onset of stroke. And the best part about doing early mobilization, it might potentially prevent that 70% of the survivors who die within 3 to 5 years post-stroke. Early mobilization, again, what is it? I want to introduce you to Daryl. This is my brother-in-law. A few years ago, he had an ischemic attack on the left. He was in a rural place in Ray, Colorado, very small town. They did not have the capability of doing CT scans at this hospital. So they took a chance. My sister said, go ahead, provide the TPA. They flew him to Denver. During that flight, he bled. So he actually ended up with a double stroke. So by the time I got to the hospital to meet them with the when the helicopter got there, he was obviously in ICU. We got him to the point where he was medically stable. And so I immediately started with the therapists at the hospital with the permission of the nurses, and they knew exactly what we were doing. We started working with him, just very small things that everybody here can probably start doing, including the caregivers. First of all, have the patient attend to that affected side. Don't let them looking over here. If you're going to talk to them, talk on the affected side. Get them to look at you. Get them to attend. Get them to reach with or without assistance. Use their other extremity to move them. Daryl had a little bit of trouble with that because he had the double stroke. So we ended up having to help him move for a while until his left side was more mobile. The one thing that I found in when I work with my patients and my clients is that we have to speak to them normally. I've heard so many people raise their voices, even their family members will raise their voices, talk real slow to them so they understand, but you may have to give them some time to process. So we allow them lots and lots of time for process. And one of the things that I have learned through my years of doing this, we need to encourage them and teach them correct movement patterns versus non-use of the affected side. Just keep using that unaffected side, that's what they're going to do. They will continue that for the rest of their journey. The mobility, we started doing passive range of motion, active assistive range of motion of both the lower and upper extremity. So we worked on that with him. Again, depending on the functional level of the patient, I saw the last one, we increased the head of the bed, sitting on the edge of the bed. And these are the mobilizations that the AVERT study uses. Sitting on the edge of bed with or without assistance. They might be able to sit with you or without you or with a caregiver, a therapist. Sit to stands, sitting out of bed in a chair, standing at the edge of the bed with a walker, with assistance. Begin walking, stepping, and marching. The biggest thing is to get more out of bed time and depend on their functional level, decrease their rest time. So you nurses, staff, the early mobilization sets the stage for the stroke survivors' recovery. From the day the nurses meet, from the day you guys, nurses, staff, meet the patients, those patients and their family are beginning a lifelong journey, learning new ways of living. And one of the most important aspects of recovery is hope. I know that's not a medical term, but it is hope that drives them because it's necessary for them to believe, and they have to have a reason to work, to fight, and to take an active part in their own recovery. So let me introduce you to the miracles of what happens when patients have hope and they believe. Start talking.
Hi, my name is Tony Cherry. I am 58 years old and had my stroke at 54. When I woke up from it, my neurologist asked me to move several of my extremities. When I was unable to, he told me that that was as good as I was going to get. Now, mind you, nothing moved. And now, mind you, also, this is a doctor. And I told him, bullshit, you don't know who I am. And this is not going to, I'm not going to be like this for the rest of my life.
So this is really important to me in my practice. We as health care providers, we have to encourage our patients with a will-do attitude so that they don't go out in the world thinking this is as good as I'm going to get, because that is not true. We all understand the principles of neuroplasticity, and that the sooner we get to working, the sooner that brain can continue to function. One of the things that was brought up in the AVERT study was, yes, having frequent mobilizations, being with the patient more often, less dosages, that's a whole staffing issue and a whole hospital puzzle that your hospital will have to figure out. But what we do need to have clear communication between all the disciplines. We need to have more defined and specific mobilization protocols, because that's still out there for debate. We need to have good and effective training for all the staff. That includes the nurses, PTs, OTs, speech therapists. We all have to have a better teaching on safe mobility. And we need continuity and repetition of the therapy delivery, and that's really important. And then we also, and this is really important, strong post-case management for maneuvering into the next stage of the recovery. Where do they go post-hospital stay, acute care, where do they go? And we really need to have a stronger staff taking care of that. It's not advancing. There we go. So with my clients in my world, we look at what is possible. We look for salient goals, short-term and long-term, because if it's not important to them, it's not going to be important to work on it. So as a team, we overcome those barriers. So in my practice, we use roughly, loosely, the principles of neuroplasticity. Use it or lose it. We use it and it has improved, and it does improve. We use a lot of specificity, a lot of task-oriented activities. We do a lot of repetition, practice, practice, practice. We also work with the patients, with their families and their caregivers, to make sure that they are transferring what we do in our practice to home. Now, my clients come in from anywhere from 3 to 6 hours a day. They're with me all day. I have 3 therapists and another PTA that I work with, and some volunteers that come in and help with their speech recovery. So we also do we work on shoulder mobilization, just like some of the things you would be doing in hospital post-stroke. So we do mobilization, stretching, strengthening, so on. So I'm going to introduce you to some of my patients. So this is Rudy. Rudy had very little mobility when I first met him. Actually, when I first met him, he was in a wheelchair. He has aphasia, was not able to communicate well with us. But with the aphasia, he couldn't tell us what he wanted. So he and I learned to talk to each other. And he wanted to ride a Harley. He wanted to go back to riding his Harley Davidson. So we worked and we worked and we worked and we practiced with using different methodologies. And after about, I don't know, probably at 6 months to 8 months. Oops, Kevin, oops, we gotta go back. There we go. Rudy was able to grasp the T-bar by himself, and he was able to move it without any assistance. This is a huge milestone because he had no mobility when I first started with him. And I've known most of these patients anywhere from 10 to 12 years. So I got to know them pretty well. One of the other goals that Rudy had was to speak and to be able to express himself verbally. He had a couple of devices which he hated using. So
say flamingo.
Lingo. Ling.
La.
La. La. Mingo.
Put together.
La. Mingo.
Got it.
that was early on speech practice. He picked the words, we practiced them. And then after time went on, we continued to talk. We started putting words together, and this is what we ended up getting.
Morning. How are you?
Fine, thank you. How are you?
Fine.
So let me tell you a little story. His sister called his house to talk to his wife to see if they were coming for Christmas dinner. And when she called, Rudy picked up the phone and said, hello. And that was the first time he had used the phone or talked on the phone since he had his stroke. His sister was so thrilled. I'm gonna start crying. His sister was so thrilled that she called me, and I panicked because I thought something was wrong. She called me and let me know that Rudy had picked up that phone and talked to her for the first time since his stroke. So we were very tickled and thrilled, and we were all crying because we were so excited about it. So this is Lindsay. Lindsay had AV malformation, and her stroke was at the age of 26. But she is the most determined woman that I know and has become a very dear friend. And she's an inspiration to all. She practices, and she practices with struggles.
Slow down. Up.
And after we practiced this a few times during that one session that we were there that day, this is what happened.
And your hand's gonna go from the mat to your knee, not to me.
So watch the therapist
Leaning
as she pull her
forward.
hand away. Won't let her
There you
try.
go, there you go. That's nice. Get taller. Tall, you can do it. Tall, hips underneath you. Shift to the right a little bit. Just gently use me, not heavy. Find your balance so you can let go of me. Yeah. Now bend your knees. Bend your knees. Head towards the floor. Head towards the floor. Much better. That was really good.
So Lindsay is a triplegic. She only has one typical arm. Everything else is either flexion tone or extension tone. Lindsay can now stand on her own. She can sit to stand without any assistance, and she is able to walk 75 to 100 feet with a handheld assist only. So she's one of our miracles. This is Nick. Nick came to us 3 months post-stroke. He was full max assist on sit to stands, but he ended up mastering that, and he is now capable of sitting to stand all on his own. But the biggest thing he wanted to do was to walk. So he took on the challenge. So we started off with a max assist of 2.
And kick it through.
Notice how she's having to advance his foot forward.
Good. Look up. Look up tall. Kick that foot through.
And then we went to a max assist.
You feel how you're leaning away from me a little bit, Nick? Can you feel that? This hand, so see if you can balance a little more yourself than on my hand.
I'm excited with this.
Okay, and then about a year later,
Oh, you got it, you got it, you got it.
the
Yes.
time he walked 10 feet with contact bar to stand by his side.
It's all you, buddy. Oh, a little farther with the right foot. I think that was 4 in a row.
That's Nick. He is 83 years old. I'd like you to meet Doug. I met Doug when he originally came to see us. He was in a wheelchair and he had aphasia and very limited words. But Doug decided at that time when I first met him that there was nothing that was going to stand in his way to do what he wanted and needed to do. So Doug now, he mows his neighbors' lawns. He mows his church lawn, and he plows snow in the wintertime for his neighbors and the church. So he also works on his mower and his plow on his own. And so that required him to get on and off the ground so he could get underneath the machinery. So this is what we worked on. We practiced proper mobility, proper movement patterns so that he could get down on the floor or get down on the ground. If you ever tried this with one hand, oh boy. And then after we practiced over and over, he was able to complete his task. Again, salient goals, things that they need to do, things that they want to do. It's very important. So Doug drives, he works around his yard, He makes repairs on his house, and last summer, he built a house on the back of his, and a deck on the back of his house. So can it be done? Yes. Okay, so you met Tony before. He's one of my heroes. He's got very good verbal skills, and often, yeah, we won't go there. So he has 2 cats that he has used to get on the ground with and play and rustle up, but because of his stroke, he could no longer get on the ground, and the cats became very confused. So he told me, he says, I want to get on the ground, play with the cats. So we had to work on tall kneeling. We had to work on reaching. The other goals that he had was to hug his wife with both arms, which he did, and walk around his neighborhood. And heaven knows why, but he wanted to walk on a treadmill. So we worked with him for months. He had no mobility on that treadmill at all. So we had to have 2 people working with him. It was a max assist. We had people holding him. We had a light gate. We worked on his feet, the mobility, movement patterns of his feet, proper mobility, proper movement. And after, I think we were at 6 months of working with him, this is where he was able to do.
She likes to go to coffee shops and restaurants.
Do you want some commentary?
I thought about that. I really truly thought
I
about
gotta
that. I
behave,
need to,
which that's
I
really
need
tough.
to know her a little bit better.
The great thing is
But,
you can have a
this
conversation.
is.
Yes.
Oh, the coffee shop.
This is Diane. Diane, again, she has aphasia. And when I say I talk to my clients, I do, and we communicate. What the things that she was really frustrated with at home was that she was not able to help her husband. So I asked her, I said, okay, what do you want to do? And she said, I want to fold clothes. I want to help set the table and clear the table, and I want to make the bed. I said, all right, let's take the challenge. So we started off with very small things, folding a washcloth, doing things that were very small. But eventually we had to move to the bigger things because that was part of her goal. So she started folding clothes. And the reason she's wearing gloves is her hands were very, very cold all the time. So a friend of her made her some special gloves that she could put hand warmers in to keep her hands warm. You can tell by the smile on her face how happy she was. The next slide is we talked about setting the table and clearing the table. And I allowed her to figure out how to organize and move whatever she needed to the table as quickly as she could. So she's kind of the person that wants to walk really fast. So we worked pretty hard on getting her to bring things to the table. And after she figured out how to get everything there, this is what we ended up with. And she set the table.
See how happy you did? Yay.
So you can see the joy in her face for to accomplish something that's a very good goal for her, and she was able to help in the house with her husband. So in our practice, we do use the brain-body connection, the neuroplasty, with mirror therapy. And if you aren't familiar with that, basically the mirror therapy is where we put the affected side behind a mirror. They look in the mirror using their unaffected hand, and it kind of tricks the brain into thinking that the affected hand is actually doing the mobility. And there's a lot of research behind this, and we found it to be pretty effective. This is Rudy doing his therapy. And if I don't have the video behind the mirror, but at one point he started moving his unaffected hand equally to what he was doing with his unaffected hand. And we also developed a program for the lower extremity as well. We also use motor imagery, or this is immediate feedback. And basically what this is done, the computer is set up with a glove that he can show the mobility on a screen. So if you want to go ahead and play that, Kevin, real quick. You can see the dial move as he moves his hand. And then he can reset it and try to reach again, go higher and higher with this mobility of his hand. So I've discovered that challenging our clients, they will rise and they will overcome the challenges. And I won't play this long. I know we're running a little over on time. But I do know that they will rise to the challenge. And they have some fun doing it. So this is again is Lindsay, and Lindsay wanted to ride a bike. And so she was able to overcome her fear, and she was able to power this bike on her own through a tone.
Wow. Amazing.
So through the repetition, practice, hard work, belief, and hope, here's Lindsay and friends getting to participate in some fun things in life. So why is early mobilization and doing frequent out-of-bed task-oriented activities and getting to know our patients so imperative? To give them hope so that they can achieve their goals of greater independence in their life, of the lifelong journey that they're taking on. But the hope is experiencing the best of the quality of their life, experience a raft trip on the Colorado River with family and friends, actively maintain their cardiovascular health so that driving becomes a reality for Don.
We'll see ya.
Bye.
Bye. See how easy that is? Yeah. Huh?
Did good though. Look at that.
Yeah.
So that Tony can share his talents. He painted the picture, let's see, it would be on your left. It was a wedding gift to my husband and I, and it was inspired by our wedding invitation. He painted this for us in acrylics. For Gary to ride the Grand Tetons with his son. And for Joe, we got to introduce you to Joe. Joe came to us wheelchair bound and with aphasia. And when Joe's daughter got engaged, he wanted to walk her down the aisle and give her away. And that was his goal. And that was his hope. And after a little over a year, Joe did walk his daughter down the aisle on an unlevel surface on a mountain top. And he was able to tell the minister, when the minister asked, who gives this woman to be married to this man? He was able to reply, her mother and I do. And as a bonus, he was able to dance with his daughter. You can just tell by the smile on his face. So this is why we start early mobilization. And after a stroke, there is joy, there is hope, and in the beginning, it all begins with you. Start early, plant the seed of hope. Diane's story again. One day I caught her tapping her foot and swaying to some music. I asked her if she liked to dance, and she said yes. And I said, did you used to dance with Steve? And she said yes. I said, would you like to dance again? She said yes, very much so. And so for a surprise for her husband's birthday, we practiced so that she could dance. Oops, go back. Dance with
Oh, wow.
and they could have friends and have fun and be socially interactive. So this is why we all do what we do for our patients and our friends. So thank you again for having me.